Hello, this is Jen, and this is my week 12 discussion. And this is about Elizabeth and her lack of clotting factor and needing expensive experimental treatments and lack of resources from my hospital. The number one question, or question number one, was what should the Clinical Ethics Committee advise for discharge planning? This will be a large discharge planning and probably very extensive. She should be told that she is clinically stable for the moment, but she is at a high risk for hemorrhage. She needs to be told about all the precautions she needs to take to avoid bleeding due to her lack of clotting factor. Where you and I would get a simple little paper cut, she would probably have a massive bleed. She needs to know that the medication that she requires to stop her bleeding is experimental, and it will be difficult and costly to obtain at any hospital. Whether she picks the rural hospital, our hospital, or another hospital that has more resources than we do, they're all going to have difficulty getting this medication. The patient or the hospital she chooses can talk to the manufacturer of the product to see if they can help get the medication to the rural hospital or whatever hospital she chooses. They might be able to keep some of the medication on hand, maybe like at her rural hospital, if the hospital and medication manufacturers are both in agreement on this. However, the hospital, like I said, we don't know when her next hemorrhage is going to come. We don't know, and we don't know how stable the medication is, how long it takes to make. There's just several unknown factors there that should be part of the discharge planning. Elizabeth needs to know the benefits and risk of having this experimental medication given at the hospital. She needs to be told about the hospital's budget and what sacrifices we have had to make for her to stay at the hospital, or when she's readmitted. If she needs to be readmitted, we'll talk about it again too. This includes a possible lack of resources for other patients. She should be told what a big hit we're taking to take care of her. She might be concerned and decide not to do the treatments anymore as they're not helping that much. Or she might, go the opposite way and say, that's okay, well, I'll have you guys pay the bill. She could be referred to a hospital that is more likely to be able to have more resources for her. They may even be able to help her find a reason behind the lack of clotting factors. So if we refer her to a different tier hospital, like I said, maybe they'll find a cure. We're not able to do that at our hospital here. We can't seem to figure out the reason for her clotting factor spiking up at age 55 years old already. So, what degree does the medical professional's ethical obligation to advocate for the patient in their care at this moment trump an obligation to conserve scarce resources to potentially benefit unknown patients in the future? I believe that when the care of one patient puts the care of several patients at risk, it becomes time to start limiting costly interventions for one patient. I would explain to the patient that the hospital does not have unlimited resources to keep administering these experimental medications that are, they're like putting a band-aid on the bullet hole. Once we get the bullet out and figure out what's causing the problems, it's just going to keep having to be treated. Let her know the hospital resources are scarce and due to the high cost of healthcare, and we can't afford to keep doing this. As our hospital is not able to provide the right resources, we would recommend probably a transfer to another hospital if she was ever to be readmitted. I believe a medical professional's obligation to advocate for their patient could trump the obligation to help future patients if there was a cure in the future or an end date for the patient's treatments. If we were only doing one or two more treatments, that might be fine, but there is no current end date right now for all of her treatments, and it'll most likely continue to be ongoing unless they find other treatments for her. If there was a different treatment that could help her clot after she just received one more dose of the experimental treatment, it'd be worth doing. The biggest concern is not having a stop date for these infusions or this medication. The American Medical Association does call for healthcare professionals to require that policies be explained to both patients who are denied access to limited resources and the public. When access to care is denied to patients because of lack of resources, then the information should be shared to the patient so they know what's going on. I don't agree with the American Medical Association here because I think going public with some of this information and what they're going to pay and not is just looking for a HIPAA violation. And patients do have the right to their own private information. What is the organization's ethical obligation in this case? It's not really too clear on here, but the organizational ethical obligation is to present reasonable expectations of clinicians, responsibility to navigate clinicians' collective negotiations with the family, enable staff justifiable judgment of a disciplinary action against the organization members. We're also going to maintain cultures that discourage misconduct, sufficiently communicate and responsible leverage organization. They aim to promote shared discussion, making crafting solutions when there are few or no alternatives, and maintaining good public relations to foster trust. They could also have structural decision-making guidelines that they use when they are deciding or not deciding changes in their own thoughts and discussions. The organizational ethics is involved in both clinical and medical ethics in the institutional policies and actions, effective patient care, and business ethics in a way. In that way, many institutional issues are primarily business concern involving financial matters, strategic planning, and complacent with legal regulations. Issues that do not directly affect patient care. So the organizational ethics are there, but they don't directly affect bedside nursing or bedside care. Healthcare organizations, of course, also have business relations with the patients concerning payment of the bills and insurance matters. It doesn't have anything to do with the clinical aspect. It doesn't directly affect patient care, but it does deal with the patients with billing and insurance, which some people believe is more critical. The fundamental difference between organizational ethics and traditional healthcare ethics is scope. Traditional ethics focus on the individuals, and organizational ethics focuses on health population, the collectives. The next question: has the ACHE issued an ethical policy statement or policy statement on this or similar issues? And of course it has, because we've done a couple of these discussion boards now. However, it's not as clear cut in this case. It's been other examples that we've had before. They are recommending that leadership responsibilities for healthcare executives include managing their organizations efficiently and effectively to help control healthcare costs that might be associated with expanding coverage. If the facility continues to provide care for the patient, there's the possibility of severe sacrifices to future patients' health. Now we're going to go on and analyzing the toolkit, the 6 multi-step process for ethical decision making. Step 1 is the background. Just a few key points here: that Elizabeth has a clotting factor disorder with no cure. The next one is there's a very expensive medical treatment that has improvement, or that is experimental but has improvement. That's just been released. That was released for compassionate use to stop the bleeding for Elizabeth because of her lack of clotting factor. It was given. The experimental medication was given, and it worked for at least a short term. There is no determining how long Elizabeth will need to go on this experimental treatment. The other thing is Elizabeth's treatments or cost of care was $1.7 million, and so far the bills continue to come in. And Medicaid will only pay $42 million. I'm sorry, $42,000. I misspoke there. That's a big difference. Step 2, we're going to identify the specific ethical question that needs clarifying. Should the facility continue to provide treatment with this experimental treatment, which is still in the experimental phase, only released for her for compassion, because it might be a lifelong treatment for Elizabeth. This has possibly, though, to compromise patient care in the future. Step 3, consider related ethical principles and or organizational values. The organizational values and the healthcare professionals want to supply the best care to the patients. What the patient would like to do is not discussed in this actual case study. Determine the options for response. Number one, we can tell the patient you can no longer provide long-term care for her at this time, and she will be denied care if she needs treatment. The next thing is we're going to tell her to go to the nearest emergency room if she needs care while she's at home. Which we're aware that the closest rural hospital doesn't have access to this experimental medication, so we'll have to work on that. Refer to the hospital. I'm going to refer to the hospital that has more resources than your hospital, or than my hospital, as they may be able to provide long-term care. They are also may be able to complete a more specific testing to determine the causative factors. Step 5, a recommended response. I would recommend she be discharged from the hospital with extensive discharge planning and recommendations stating only to use certain experimental products on her. This might save some resources, like the full workup that we had to do, and may not be effective. This might have saved some resources. And like I said, when we go to other hospitals, we're not going to have to do all the steps that we did to get to this experimental treatment. Then, of course, we were billed for everything before that. So hopefully now the hospital can just start with that experimental treatment as it's proven, documented, the only thing that works. I'm going to encourage to contract. I'm going to encourage them to have a contract established through the rural hospital and experimental drug manufacturer. If we can guarantee so much of the drug on hand, that would actually be good for the drug manufacturer to be able to bring it in and have a solid, where someone's going to actually buy it, and the rural hospital will be able to take care of Elizabeth. Anticipate the ethical conflict. Oh, we all know what's coming. The ethical conflict. The facility is currently able to provide experimental treatment, but how long can they do that before it starts to affect patients' care? Is the health of one patient more than the other patients? And what is the current health of the patient? The question I'm going to ask is, if you were in the position of the patient, what would you do? Would you continue the treatment knowing that there's a possibility of a cure coming up? Or would you say it's not worth my health to save others and self-sacrifice? Please leave your responses in the reply. Thank you.